where we were on the type 1? Okay. Okay, here we go. We'll let Zoom kind of get in here, but we'll go through the skin test. I guess we talked about, some of you had the skin test. So you've experienced this where it's in vivo. So you can either do the precutaneous or the intradermal. So you're basically putting in the allergen and see if you have a reaction. So as you see spider on this guy, moth, caterpillar. So if you got any of those, tick, scorpion, let's see some more. Honeybee, worker bee. So his biggest sensitivity is to who? Spider up there. So spider venom, scorpion venom, definitely would react. We call it a wheel and flare. That's very common for a positive test. And if you had a TB skin test, kind of the same thing. They put the antigen under the skin, and if you've been sensitized to TB, meaning you've been exposed to it in the past as a healthcare worker, you'll get a wheel and flare. So it'll raise up and it'll turn red. And I just did one a couple of weeks ago. It seems like, no reaction whatsoever with mine for the umpteenth year in a row. CDC, I did find this out. CDC has recommended not to do annual TB skin tests on healthcare workers. So now they're only asking you to evaluate your own exposure. Have you been night sweats? Have you experienced any of the symptoms of tuberculosis exposure? So if you haven't, you just sign off and say no. And that's your kind of annual review now. You don't have to actually go get a physical skin test anymore. We had seen with some of our students that they had kind of quit doing the skin test. It became harder and harder for a student to go get it if they weren't a healthcare worker already. And they'd gone into like a spot test, like a blood spot of some kind of test some doctors were doing. But it was getting harder and harder if you weren't actually in the facility to get a TB skin test. So allergen-specific IgE testing used to detect IgE-specific allergen in a patient's serum. You kind of have seen this, right? Oh yeah, we have a lab midterm today, right? Yeah, I finished that, so now you're all awake, right? I can tell you that it's 10 questions, so don't stress out. It's not going to be this massive.
So if I miss words.
What's that?
If I miss one, if I miss two, I'm done.
Well, yeah, you're not going to miss any though. Right?
What are they short answer?
What's that?
They're short answer?
They're short answers, yeah.
Partial credit?
Yeah, you get partial credit. The partial credit's really going to come on the dilution problems. Okay, so show your work, show me what you're setting up, and just if you don't quite get the right answer at the end, yeah, you'll get some partial on that. So, but yeah, there's more of those than anything else. So dilution problems are what we've done most. So I worked through them last night. They all seem pretty simple and easy.
Well, yeah.
They're basic. If you'll remember our rules of, things like total volume. Don't forget to add those up to get total volume. That's kind of the key starter for every one we do. And just make sure you know what units you're in and that type of stuff. And make sure you put units. If they're asking for like meals, put meals. If they're asking for moles, put moles. Don't forget that, okay? If they're just asking dilution, just say dilution, 1 to whatever. Or draw it, in a fraction form. That's great. But yeah, it's just a check. It's dilutions, it's ELISA, it's antibody titer, and pipetting. I think those are the four things that are on 10 questions that you need to know a little something about. But yes, you should be fine.
So it's 100 points.
It's a 100-point midterm, yes. Yeah. But I wanted to give you time to do those solution problems. So I didn't want you to sit there and go, oh my gosh, you only gave me 30 minutes and I can't figure these out. You'll have the whole session, to finish it and turn it in. But you'll need a calculator to do the dilutions, so you can calculate those and make the divisions and multiplying and all that. I'll let you do that. And we have some really cool color ones, that are in there with solar. Got them from the dollar store, I think. Those work really well. Or you can use no, I can't let you use your phone. Sorry. Y'all would be Googling at least 3 of those questions, probably, or more. Okay. Good. All right, back to lecture. Here is an IgE allergen specific. We put the antigen here to detect the IgE antibody, right? This is our ELISA, where we put the antigen in the well. If IgE is there, it binds. Then we chase it with the anti-IgE here with our substrate, enzyme substrate. If it attaches, it lights up, changes color to blue at the end. And we see that the patient has the allergen antibody, IgE antibody. So we can do this kind of testing. Y'all have done this now, right? You practice this. Used to detect the total concentration of IgE in the patient. We can do that too. This is where we put anti-IgE in the well, the bottom. And then we look for IgE. It starts to bind. And then we go, with the anti with the substrate. If it's there, still there. If it stayed there and didn't wash away, it turns blue again. So I think you're very familiar with how we go about testing for the total IgE or a specific IgE to a certain antigen. So those are our 2 different ways of doing some ELISA testing. All right. Type 2 hypersensitivity. Remember to go back to that very first paragraph to kind of get how can we sum up each one in just a few words. And what we're doing is type 2 hypersensitivity is also known as antibody-mediated cytotoxic hypersensitivity. It includes the IgG and the IgM, okay? Unlike type 1, which was IgE. So you should be good there. This can lead, when we have the antibodies, they react to the antigen on the surface of the host cell in type 2. So host cells are showing an antigenic determinant. IgG and IgM are seeing that. They're binding to that host cell, and that brings complement in behind that. And complement lyses those cells, and then they dysfunctional cell blocking and all this good stuff. But that's the basis of what's going on. So antibody-mediated cytotoxic hypersensitivity is type 2. The key components, IgG and IgM, against a cell surface antigen. So this is not what we're going to get next, which is floating and circulating. This is the actual cell of an area that has an antibody attack. Okay? So cell destruction, inhibition of that cell's function, or it can be increase that cell's function, depending on what happens with that. Okay, so let's look. Type 2, all right, so this is over on page 221. So here are the 3, I think there's 3 in here, the cell damage. It can be activation of the classical pathway, because y'all know that IgG, 2 of them, and 1 IgM can activate complement, right? So we get the classic activation causing cell lysis. We can coat the cell surface with the antibody to promote opsonization from the phagocytic cells. Okay, so we have that. So we get macrophages and neutrophils come in. They see the C3b on there, and they do phagocytosis. We have cell damage resulting from a mechanism from the antibody-dependent cellular cytotoxicity cell, the ADCC. And I think that one appeared way back when we were first talking about the different cells. Probably hadn't talked much about that one until now. Okay, so it's been a while since we brought in the ADCC cell. They're mediated through the binding of the IgG to the corresponding antigen on the target cell, FC receptors on the macrophages, and then natural killer cells come in. Okay, so ADCC associated with cytotoxic, not cytotoxic, but which one? The natural killer cells. Okay. And this one includes transfusion reactions. Y'all were talking about that, I know, on Friday. I don't know if y'all finished those stories today. Hemolytic disease of the newborn. I know y'all talked about that on Friday. So we're going to kind of review it today again from my take. And then we also have autoimmune hemolytic anemia, where the red cells are being attacked and lysed. So you'll definitely see these in blood bank coming up. This type of type 2 hypersensitivity. Activation, classical pathway causing cell lysis, also can be opsonization, but we need to make sure we talk about the antibody dependent is it cytotoxic? What does that ADCC stand for? Cellular cytotoxicity. So ADCC. It's associated with type 2. So if you hadn't figured it out, it's probably going to be a test question. Okay. So we see this. Here's the red cell, right? And it's got an antibody attack against the red cell. Okay, so this is an IgG coming in and attacking the red cell, bringing in the macrophage here to do this, to eat the cell. Classical pathway over here, we see our C1QRS complex coming in to the two IgGs bound to the red cell. So those should look very familiar to you. Type 2 hypersensitivities are with transfusion reactions, hemolytic disease of the newborn, and then autoimmune hemolytic anemia. So we have these things that you will pick up on in blood bank more so than now, but we have warm active antibodies, we have cold active antibodies. So cold agglutins are happening when we bring the blood out of the body. Okay, so we see these sometimes in our workup of blood, that all of a sudden we're getting this agglutination reaction, and it's in every tube. Okay, that's the key to cold agglutins is every tube is reacting with agglutination. If you warm it up, it goes away. So it's not happening in the body, but when you bring it out of the body's temperature and let it cool down to room temperature, then these things start to happen. You're going to get a lot more about that in next semester. All right, a couple of names, of course, they come up. I see good pasture syndrome, and I see Hashimoto's disease. Those that know anything about the thyroid, that's Hashimoto's. So this is an autoimmune where you have an antibody produced against the thyroid gland itself, the receptors. So Hashimoto antibody, that's an antibody name. So Hashimoto discovered it. Hashimoto got it named after him. And so we have Hashimoto's disease, which is an anti-thyroid antibody. Good pastures. Who can tell me something about good pastures? Because I love these names, because this is what I said, kind of again, a red light, call it red light feature here for board question, good pasture syndrome. Who can tell me something about good pastures? Is good pastures even in the book? We got it in here anyway. I see the Georgias. That's over there. That's back of pasture. Back a lecture. That's yesterday. Where's Mary? Who's? Who's on Google? Anybody who wants to Google good pasture? Not in the book?
I'm not seeing it in the book.
It's not in the book? What is it? I thought I read
So
it.
we've got Hodgkin's disease, Waldstrom's. But
Yeah.
I'm not seeing.
It's in the back of the book.
It's in the back of it. What does it say?
It says an autoimmune disease characterized by the presence of an autoantibody to collagen and the tubercular, I don't know.
Okay.
It says here on page 224 that an evenly bound linear deposition of IgG in
Oh, here it is over here, isn't it? Yeah, it's way in
basically
front of
the
us.
brain.
It's way in front of us over here. Right? BAT, good pastures. I found it. Good pastures on 224. Goodpasture syndrome is an example of such a disease of a type 2 hypersensitive that involves tissue antigen. Because remember, we talked about the antibody goes where? The reason we're spending time on Goodpasture. The antibody goes to the tissue where the antigen is located. So these are directed at the tissue level. Goodpastures, the antibody produced during the course of this disease reacts to the basement membrane protein, usually glomerule of the kidney or lungs, pulmonary. So again, this would be one that what provokes your kidneys to be unhappy. And when you're in body urinalysis, when you talk about protein, or you're in clinical chemistry talking about protein in the urine, that is the key. We'll see this. We can screen. So why you're like, why do I do a urinalysis on every single patient that comes through? Because we can check the kidneys with urinalysis, not just looking for urinary tract infection. We're not doing that. We're actually looking at protein. We're looking at hemoglobin. We're looking at what else? What else we got in the 10 square urine dipstick? You might know. pH, right?
You can have crystals.
Crystals, well, that'd be an examination, but you can see crystals by, again, protein increase, right? You kind of know what's in there. Specific gravity increases, you got stuff in there, right? So all this urinalysis, we think, oh, as a med lab scientist, we're just wasting our precious time doing urines after urines after urines after urines, right? But we're actually giving a healthy view of the kidney function. Just like with our chemistry panel, our BUN creatinine, that's checking kidney function. Okay, we look at liver function. So we do, several of these are looking for unhappy kidneys. Hemolytic disease of the newborn. Yeah, I've already had this, so I'm not going to spend a whole lot, but we do have a picture. We have a picture here on 14-7 figure, 223. Basically, you know, I heard Friday y'all got this, right? Caused by development of an antibody by a pregnant woman to the red blood cell group antigen, usually RHD, on the red blood cell of the fetus. So, to give you my take on it, it's the reason we ask about not how many babies you have, but how many pregnancies you had. And that's the doctor's way of figuring out if you've had any issues. So these are our negative moms. So Rh negative mom is the susceptible to this by having a positive baby, having an Rh positive baby. Doesn't have to be a live birth. It can be the first pregnancy we had. We lost a baby, okay? Or we had surgery, or we had traumatic issues. So the very first exposure, this can be cc's of blood. This doesn't have to be an ongoing bleed. It can just be a rough rough delivery, right? Forceps being used, scratches on the forehead. Arm comes out, it's got a scratch on it from just coming through the birth canal. Any of those kind of things can expose the mother to the Rh blood, okay? If the mother is sensitized to that, meaning she gets a reaction that she's going to produce an antibody against that, the first baby is usually healthy, good, great, right? It's the second baby that we don't know the second baby's blood type. And if we don't treat the mom the first time with a RhoGAM, or have the mom on RhoGAM during the second pregnancy, okay, to take care of the antibody that's there, the anti-D. So mom now has an anti-D antibody. That does cross with placenta, okay? And it can cause harm to the second baby, even in vitro. In vivo, sorry, in vivo. We're doing in vitro downstairs. In vivo, and we can lose that baby. And so that baby can be a stillborn. We can lose the second one or with the blood, the baby comes out and needs a blood transfusion right off the bat. We're talking, we check the hematocrit. So we check babies for this. You know, the reason we do baby checks, right? You gotta do a heel stick on a baby. We need an H&H on that baby right now, okay? After 1 hour of birth, we go down there and we check sugars and we check their hematocrit. And that's just to make sure they're not in this state of hemolytic disease. But we do, and then you say, well, yeah, I remember they did that with my mom or my wife. My wife's Rh negative. And they did that, so what's the big deal, right? You'd be amazed how many times in an ER setting that the very first exposure to a doctor during the pregnancy is at delivery time. Okay, so you have no history whatsoever. So we're working up that emergency delivery that just walked in the door in labor and going, I haven't seen a doctor. You know, so we see that quite often, especially in rural hospitals and maybe big city hospitals too. Like, I got pregnant, I didn't see a reason to go to the doctor, and now I'm having the baby, so here I am. And we don't know mother's blood type, we don't know babies, we don't know her history, we don't know how many babies she's had before, we don't know if she's Rh negative and now having Rh positive babies, we don't know. So we have to do quick OB pre-birth that day, that minute, that hour before, and you may get finished before it's born, you may not. Depends on how quick you are about getting all that done. But we think about, for micro, we think about group B strep. You know, is the birth canal loaded up with group B and baby's fixing to come flying through that? We don't know yet, right? We hadn't done those tests. We definitely hadn't done the hemolytic disease in the newborn. So here's our picture showing our Rh mother. Okay, and then we see that we have the antibody being produced. The second pregnancy is the one at risk. Here's the Rh second. And we don't know that. We don't know, right? And like with me, my wife's Rh negative, but I'm Rh positive. So, you know, good chance we're going to have an Rh positive baby. And luckily, you know, we made it through a second birth with no problem. And then the RhoGAM is given after birth and given before or during the second pregnancy. They give RhoGAM again just to make sure that there's none circulating. And it binds, as you see, it binds to the red cells. Is that what it's binding to? Yes, RhoGAM. To take out any Rh positive blood that mom might have got exposed to before she gets sensitized. So it's a good way of desensitizing mom. So you'll hear something called a direct antiglobulin test. Anytime we suspect a transfusion reaction, okay, where the patient is receiving blood and all of a sudden the patient is having problems with that receiving of the blood, we can, if we think a transfusion reaction has happened, we do a DAT. What that is directly looking for the antibody bound to the red cell. And that's in blood bank terms, that's why it's called direct. So the reaction has occurring, which means the antibody in the patient is actually binding to the red cells that you just gave them, okay? So we can pull that blood and check it for a DAT. So we basically take the patient's blood, it's coated in antibody, and we have anti-human antibody to chase that, and it agglutinates in the tube with about a 10-second spin. So these take 10 seconds to do a DAT. You draw the blood from mom, you put a drop of blood, dilute it in a tube, you add the green stuff, is what I call it in blood bank. You add a drop of anti-human immunoglobulin to that tube, spin it, and if it agglutinates, you got a positive DAT. That's what the doctors want to hear because they'll know they're having a transfusion reaction, okay? And then we have issues where we take urine to look for lysing of the blood in the urine. And we also can look at the plasma. We spin that plasma down and we'll see lysing of the red cells there too. And it just won't be because you were a bad phlebotomist, it's because we have a transfusion reaction. Okay, so that's how direct works. If positive, agglutination, test is repeated with a non-specific anti-IgG, an anti-C3b, and an anti-C3d. So these are complement, okay? So you'll take your little bottle next semester. I want y'all to surprise Dr. Walls when you pick up your bottle of green stuff, and she throws that out there to you. And she says, oh, that's the anti-human immunoglobulin. And you go, oh, I see that it's anti-IgG. I also see that it's anti-C3b from complement. And I also see that it's anti-C3d from complement. Is there a C3d? What is that? Here we go, pick up on it. Jeff here. Forgot to compliment so soon. All right. Seems like we're doing a blood bank lecture here. Indirect antiglobulin test. This is called the Coombs test. And the difference is that we're not doing directly the antibody on the red cell anymore. We're just going to look for the antibody out in circulation. So we're going to set this up to indirectly detect it. That's all it is. It's just a name. Don't get caught up in the name. Okay? So we're going to test the patient's serum for antibodies against the red blood cell antigen. So this is our screen. When you hear screen, and you type in screen, okay, we're going to type the patient. We're also going to screen the patient for an antibody. So the antibody screen is for the indirect. That's how we test it. That's how we look for it indirectly. So basically what we do is we take the serum from the patient and we add cells. We add the cells this time. It's not the patient's red blood cells that we gave them that are floating around. We take their serum out of their body and we add the red cells that have the known antigens on them. So you get a bottle of antigens, right? All these red cells are mixed together. So you get like cell 1. Cell 1 has red cells with all this group of antigens on them. Okay? Then you get cell 2 that has a little different take to it. Cell 3 has a little different take. So you screen, and if any one of those is positive, right, from the test, from the indirect test, then we know the patient has one of those antibodies against one of those antigens. So everybody's red cell has these groups of antigens on them. I think your book says 27 or so, 30, I can't remember exactly what it was, 20, a big number, let's put it that way. So all this, you're going to get in blood bank, the processing. I'm not going to go through that because you're going to get this, how it works. But a positive test is agglutination. So if it agglutenates, then it's positive. So we have that 4, 3, 2, 1 agglutination to judge in blood bank. So that's the big thing I can give you today is that the difference between DAT and IAT. This one's also known as screen, antibody screen. The other one's always known as DAT. You don't get it any other way. And we're basically, it's just the process of how we're looking for it. We're looking for it directly attached to the red cell of the patient. That's a DAT. So that's a drawn red cell from the patient. Indirectly, we're drawing serum from the patient and we're adding the red cell to try to get it to agglutinate if it's there. So both of these, don't worry, both of these can be covered, I'm sure, in much greater detail, but you at least got a little intro of type 2 hypersensitivity reactions if these don't go right, all right? If they don't go right, then you'll find out that you've caused a transfusion reaction, which is never good, never good. Okay, that's what we're trying to avoid. That's why you make the big bucks in blood bank, to make sure you don't give somebody blood they shouldn't have. Okay? So this is interested in blood bank. Who likes blood bank already? You haven't even got there, but who likes it? Anybody?
I'm excited about
You're
it, but
excited?
not I like her, but I'm scared.
The good thing, the thing I like to say about blood bankers is that that's the only time in lab that we give somebody something. Everything else we're pulling from them. We're taking serum for clinical chemistry. We're taking body fluids for micro. We're taking blood for hematology. But in blood bank, we're preparing to administer in some kind of therapeutic aid. So we're getting ready to give them packed red blood cells. We're getting them ready to give them platelets. We're getting them ready to give them plasma. So that's the reason I say if you're interested in blood bank, that would be like, oh, yes, I like that point. I want to be involved in giving them and making sure it's safe. And you're just a stickler for everything being done right. And you won't let it go unless you're 100% positive that it's going to be okay and safe. That's what we want from blood bank, right? Everything else is like, oh, I got a CBC result. Okay, that's heme. I hate to downgrade heme, but it's heme. But then micro, it's like investigation, 2 days of work. Hey, I'm working up this one blood culture that I had yesterday. Gosh, I need help, right? I needed y'all yesterday. I had a blood culture positive. And I was like, should I call and ask my micro students for help? Like they just had a test over this, so I'm trying to be curious. They had a lecture over this, so we got a little time. So here's the micro dilemma I was in. No, Preston's back there going, I'm not in micro. Why are you talking micro? But here it is. I had a positive blood culture, right? And somebody else did the gram stain, and this is what they described the gram stain as. I see gram negative rods. I see gram positive rods. Gram negative rods are in chains. Okay, sound any? Okay, I know that's kind of the same look I gave. All right, so I grew it out. I put it on. It was plated, so I got the plates out yesterday, and of course it's growing. Okay, it's growing on chocolate. It's growing on blood. But it's not on McConkey really, like really good. It's kind of foggy in the corner. So it's not really, it's little bitty colonies up in the corner of McConkey, but I can see the color change and I can actually see a film up there of some growth. So I started my testing, right? I started like, so first I did a gram stain. It's definitely rods, okay? It's definitely rods. Mostly gram negative, okay? So most of my gram stain is negative, but there's some purple popping around. And it definitely looks like maybe a coccobacillus look to it. I don't know. That's kind of where I ended with it. So I started testing it. So the first thing I did a catalase test. It's catalase positive. Okay? It's definitely catalase positive. I did an oxidase test, and it's oxidase positive. So it took me out. That took me into a different, your little sheet we use, I was like, I even got that out. I was like, where am I on this chart? Where did I just go? Right? Is it gram negative? So I just had to say there's groups of things it may be, but gram positive rods we're about to hit that in micro, and those aren't fun. Those aren't the ones you want to see. So when they had gram positive rod written on that little gram stain report, that's not usually a good sign of something we want to. We can't figure that one. We usually can't ID gram positive rod. Gram negative rod, of course, we could, but not in that category, right? We're thinking we should be somewhere else with some negative, especially oxidase negative, and it's oxidase positive. And so anyway, I need help. I need help. So of course, I just set it up on a gram negative ID panel for today. And I don't know yet what it's turned out to be, but y'all can take that and you can tell me what you think it is. And I'll report it in micro tomorrow on what it ended up being. I hope it was something good. I hope it's not just, it's probably contaminant, and, because it was there, and it was definitely a single colony, and it was definitely growing better on chocolate. But it was still growing good on blood. So I don't think it was in the vein of Haemophilus or Neisseria. But it could be, I don't know. So I'm just gonna wait and see. But y'all help me, y'all try to help me figure it out. Type 3 hypersensitivities. These are complex mediated hypersensitivities. That's their name. And the key component is the IgG and the IgM are soluble. Okay, so these are floating antigens. So they're circulating antigens. They're small antigen antibody complexes that precipitate out and deposit in the tissue. They end up in the kidney. The kidney becomes very unhappy when this happens. C binds, vasodilation and vasopermeability increases. As you see, complement here, binding. That's what C binds means, complement. You see the C1QRS complex with 2 IgGs. This is a big, massive complex, okay? This is tissue. You see the blood vessel lumen. You see neutrophils moving in and out of the area. They're being affected to the areas. They release their lysozymal enzymes, resulting in tissue damage. So we get damage to wherever these end up. Okay? Wherever these soluble complexes find a home, we get tissue damage. Okay? The Arthus reaction. This is the skin reaction caused by type 3 hypersensitivity. Maurice Arthus In 1903, he used rabbits that had been immunized to produce an abundance of circulating antibodies. Arthur showed that when these rabbits were challenged with an intradermal injection of the antigen, they had a localized inflammatory reaction. The reaction, which is characterized by erythema and edema, peaks within 3 to 8 hours and is followed by hemorrhagic necrotic lesions that may ulcerate. Okay. Inflammatory response is caused by the antigen antibody. Combination of subsequent formation of immune complexes depositing in the small dermal blood vessels. Complement is fixed, and we go. So again, here's Arthas making an injection, causing the reaction, localized inflammation, peaks at 3 to 8 hours. We have also known as serum sickness. Serum sickness is associated with type 3 hypersensitivity reactions. Need to know that. This is caused by passive immunizations of humans with animal serum. Why would we do that? How would we do that? Before the advent of antibodies or vaccines, serum sickness was observed more often because horse antiserums were used to treat infections of diphtheria, tetanus, and pneumonia. That's how we ended up with serum sickness. Okay, so we have antibodies produced against foreign animal proteins that are given, causes immune complexes to form and deposit into the tissue. Symptoms: headache, fever, nausea, joint pain, rashes, and lymphedema. Lymphadenopathy, sorry. So, key here, right? Animals. How do we get exposed to this now? We're not taking animal serum anymore, but we may be doing what? Probably some of the autoimmune stories that we're going to be talking about later. Antibody treated animals, right? Chicken that we eat. How much of antibodies are there that's been treated with it? Are those complexes that we eat, is that exposing these to our immune system? Is our immune system reacting kind of like serum sickness against foreign protein, right? So, of course, if you are if you're a vegetarian, right, or you're vegan, which is you take all of that possibility of a vegan, you take it all out, right? You get no animal protein whatsoever. So, something to think about as far as autoimmunity. It's being studied, I'm sure. It's definitely something we can check on. When we get to autoimmune, we got other conditions associated with type 3 hypersensitivity. We have autoimmune disease. We have lupus. We have rheumatoid arthritis. We have bee sting reactions. We have the reaction to penicillin. We have the sequelae to post-streptococcal infection when we think about kidney infections, glomerulonephritis, where the post-strep ends up causing kidney damage. Because of what? Because these complexes end up where? They end up close enough to the tissues where complement and all these lysosomes and things will make their presence known. Okay, so we're going to talk about SLE, that's systemic lupus. We've got an ANA test looking for that, and we have rheumatoid arthritis. These are all type 3 classed hypersensitivity reactions. So we got a really good group there, good group to remember, especially for a multiple choice question on type 3 hypersensitivity. So the testing, you're going to do this downstairs. We have ANA, anti-nuclear antibodies. It's a real good test, simple test. The reading of the test is more complex, but you're all going to have a slide. We're going to put some patient serum. What we want to do is we look for patients. We don't have to have a patient that has an autoimmune, but it sure is nice when we do have one. So if you don't have to announce it to the class, I'll just say, hey, we got some good serum. And we will freeze that because we like to use it over and over. But it does give us a positive patient, and that's fun. But usually all these slides have about 7 wells on them, and you put all the controls on it. So these slides are already impregnated, okay? And then we put the control antibody or the patient antibody, the autoimmune binds to that anti-nuclear, which the cells are there. So these cells are there, they change their pattern. It shows up on the nucleus. So what we get is a cell with a different nucleus look. Okay, so what we're doing basically is anti-nuclear antibodies, which are produced during these conditions of lupus and rheumatoid arthritis, they're attacking the cell. Okay, so these antibodies show up that way. So we're going to see ANA. We have that. Fluorescent staining of the tissue. Again, it's an option. We won't be doing it. Testing for rheumatoid factor, we do that. I think we have a kit coming in for that, where we can do anti-IgG against rheumatoid factor. It's a screening test for rheumatoid arthritis. You do a lot of RAs with people that are having arthritic symptoms. And then we can do complement levels, which we were hoping we would have that, and we didn't. They quit making the cell that was sensitized to show complement level. So we tried, but we do have ANA and rheumatoid factor. We'll do those in this next semester, the second half of immunology. We're going to do a lot of test kits, so you'll get a sense of that. So once we get the immunoelectrophoresis diffusion test done, then we go into the kit test for all the different conditions. But ANA is one, rheumatoid factor is another. And we have some more. I mean, we have C-reactive protein. We have syphilis. We got monos. We've got a test kit just about every day. Questions on type 3? And that finally brings us to type 4. So it's not a whole lot about type 4. With type 4, we get things to think about: contact dermatitis, hypersensitive pneumonitis, and then skin testing for delayed hypersensitivity testing. So this is cell-mediated hypersensitivity. The T helper 1 cell and the macrophage are involved. Antigen-presenting cell presents an antigen to a naive T helper, which differentiates that T into the T helper 1. The T helper 1 releases its cytokines to attract and activate macrophages. Macrophages induce inflammation. Cytotoxic T lymphocytes are recruited and destroy the target cell. Hypersensitivity peaks at 48 to 72 hours after the antigen exposure. So these are the delayed type hypersensitivities. It's type 4. So where we see this is infection with intracellular pathogens. So these are the things that enter the cell: Mycobacterium TB. We know that if you've ever seen that in your lungs, pulmonary, if you see an x-ray, it's usually walled off, okay? Mycobacterium leprae that causes leprosy. Pneumocystis carnii, leishmania, and herpes. I think herpes is probably on your list of you've heard of. You might have heard of leishmania. I know you've heard of TB, and you've heard of leprosy. All of these are intracellular pathogens that cause these delayed type 4. Contact dermatitis is our other one. So who has contact dermatitis? What do we think about? What's the big one here? I'm allergic to this. Poison ivy. Okay, delay. Like, you get exposed, you're picking your garden, you're weeding your garden, you're out there pulling weeds off trees as you're cutting them and all that good stuff, and then what happened? 2 days later, then you start to break out, okay? And it's contact, so get it on your skin, you don't know you got it on your skin, and then you show up later and you start to break out and whelp up.
I thought it was pretty instant then. I've never had it.
No.
I've never.
No, the good thing is that I found a very good treatment if you're allergic to poison ivy. Wear gloves always. That's good first, right? know how to recognize it so you're not weed eating it and splattering it all over yourself. And the last thing is that I use a
Calamine?
no, it's Dr. Somebody's soap. It's the beeswax guy. It's in that section of the store. What's the doc? I can't remember his name. I'm not sure. I'll find it. I just had it and left me, but it's a poison ivy
The
soap.
guy that's got the Epsom salt.
It's poison ivy soap, and if you think you got a contact, I found that really is helpful. It keeps me from breaking out. So it's definitely something I come in and wash my hands if I think I've exposed anything to it. I keep it under the sink in my bathroom and I just pull it out when I'm outside pulling poison ivy up. But definitely one we want to associate with contact dermatitis is poison ivy. I think you have some others. Poison oak, poison sumac. Release their chemicals, and it's urushiol is the plant sap in the leaves, and you get a dermatitis, allergic dermatitis, and then you can hopefully get rid of it. We have the last one is pneumonitis, allergic diseases of the lung, where you actually take in the bacterial or fungal spore. We see this with farmer's lung, bird breeder's lung, humidifier lung disease. So these are things where if you have and I think back, I had a childhood friend. He was an older man, but he had peacocks. He loved peacocks. He always had peacocks in his backyard. He'd buy them and he'd keep them. They just walk around the yard, making their peacock yell, and they can actually fly a little bit. But he ended up dying of bird breeder's lung disease. He went in, he was like 60-something years old, and he went in and just had this pneumonitis they couldn't cure. It's just like, that's what he died from. So it's always stuck with me when it's, when you think of bird breeder's lung disease. Farmer's lung disease is definitely another one. Fungal spores, always and I think of that when I used to go get in the grain bins, and if the grain had gotten wet, it was moldy and fungal and all that. So definitely some things we need to think about in this area, because we can have both. We can have definitely farmer's lung, but also bird breeders. This is our skin contact dermatitis from our poison ivy. Skin eruptions. We can do a patch test, and then the Mantox method of doing an ancient intradermal to check us. This is our PPD TB skin test, the Mantox method. Again, delayed hypersensitivity, could be instant too. And there it is, sticking it under and then measuring the wheel from that. And that's our summary of those four. All right, I know we went past a few minutes, and we'll see you downstairs at 12:30. You'll get your test to work on. You'll turn that in, and you'll be done with our midterm. Tomorrow is micro. For those in micro, you'll get your unknown tomorrow. But we'll talk about it tomorrow at 11 in class. But we'll be setting that up today. So if you see us running around while you're taking your written test today, we're getting ready for tomorrow. Huh? Oh, you won't know what organisms I'm setting up. All right, Zoom, we're done. I got the, I think I have the wipes up here. Yeah.